Hello?
Hey, good afternoon. I guess your time is
Stand by.
Can you guys hear me? Good. Good afternoon.
Good morning, Khaldoon.
Good afternoon.
Oh,
Good evening.
morning in America.
Good
Good afternoon already?
It's 5 p.m. there.
Yeah. Hi,
In
hi
Detroit.
guys.
Actually, yeah, it's morning, yes.
Khaldoon, can you hear me? It's Hussam Noor from Bahrain at the GIS.
Of course. Hussam, can you hear me, Hussam?
Are you still on 2700 West Grand Boulevard? Because a colleague of mine says in the afternoon there.
Yeah, we are on a 2799 West Grand Boulevard.
Yes,
Exactly where you spend good time, a good part of your life here.
Yeah, I've been touched, and I've been by sheer coincidence, I've been asked to moderate this session, and I'm joined with great people here from Dubai. And I think without any further ado, we'll introduce the panelists later on. I think I'll give the chance to you and the team at the great Henry Ford first floor cardiac cath lab with Khaldoon, and please introduce the team to us.
All right.
Go ahead.
Good afternoon, everybody. First of all, we are so thankful for giving this opportunity. By the way, we couldn't come to Dubai. Hopefully next year we will, because this is our Thanksgiving holiday, and all our family comes. I have 14 people in my house yesterday, and we did this case in lieu of coming, but hopefully my colleague and I am Khaldoon Aswad. I'm from Henry Ford Hospital in Detroit, Michigan, the Arab capital in America. To my right, my colleague and chip operator is Aswad, and to his right, our chip fellow, her name is Asrar Abdu. And my collaborator in this case, our collaborator is Dr. Pedro Villablanca. He's a structural, and I'll explain to you why we have structural. And I have Emily Walk to my right. She's our assistant. And we have Anayat in the control, Dana and Chantal, otherwise known as Shantax. So we're gonna go ahead and present the case. So can you play the slides, Scott?
Sure.
Asrar?
Hi, good morning, everyone. So we're presenting our case today. Our patient is an 82-year-old gentleman. Can go next, please, Scott? 82-year-old gentleman has a history of hypertension, diabetes, hyperlipidemia, and recently diagnosed stage 1 pancreatic cancer. He presented us with a lifestyle-limiting angina and was found to have triple vessel disease, severe aortic stenosis with a preserved ejection fraction. After that, he was evaluated by CT surgery and deemed not to be a candidate. And now we're here today.
Next.
Can we go next? This is his angiogram. So he does have distal RCA intertibial branch disease, and then on the left side he has severe left main LAD and SERG disease. Can we go next? After he was turned down for surgery, he had 2 PCI. Can we play the next one? And they failed to expand the.
So basically, the patient was offered PCI twice. They crossed the LAD, and they used the balloon, and they couldn't expand it. Sorry. So basically, I'm going to put it to the panel there. So we have a patient with a critical AS. And he has severe 3-vessel disease, including the left main, very heavily calcified, and we picked a case without any CTOs, actually intentionally for you guys, and because that's more common than CTOs. So I wonder what you guys, as a panel, how would you approach this disease?
Well, thank you very much for presenting the case. Can we have the images, please? To run the angiogram. So 82 with 3-vessel disease, heavily calcified proximal LAD with underlying severe aortic stenosis. If we need to just show us the angiograms, and we'll see what the panel think.
Okay, let me show you. So basically, we debated if we're going to do mechanical support or not, and we obtained access in the right groin. Can you show that, Andrew? We obtained access in the right groin, micropuncture, and the first problem we found that we could not deliver anything past the common iliac artery. We took a picture and we had to dilate the common iliac artery with 7mm balloons, and then we basically able to advance 45 centimeter 8 French sheath in a telescoping over the balloon. And then we got access actually in the left groin just to make sure we have a backup system just in case with the patient need to have mechanical support in an emergent or urgent fashion. And we also had to kind of dilate that vessel with a balloon. So then I will let Pedro, Dr. Villablanca, come here and explain to you what we did. So this patient has a critical AS, and I want you to kind of see what we started with.
Right.
Okay, Pedro, go ahead.
Thanks, Colin. An honor to be here. So this patient doesn't have a CT, otherwise we would have known all these, peripheral artery disease. We measured the echo an LVOT of around 19. 20 is a tri-leaflet valve. The way we size the balloon when we're doing based on echo is, again, we measure the LVOT, and depending how bad is the AS, you can upsize one number. In this case, it was 19, so we pick a 20 balloon. So you will see here the waist. When we did the BAV, we pace over the wire. So we've been doing this for years now, pacing over the wire unless you have a right bundle, which, it expedites the process and it maintains the energy when you're pacing without capturing. You can see the waist there. It was pretty dramatic waist. We reheat it again just to gain more aortic valve area with very successful results. And then we change we remove the balloon and I leave it to Cal now and his team for the PCI.
So to pace over the wire, you put actually grounding. You have to put a grounding. So this is the micropuncture needle here on the left side. We attach the alligator to it, and you attach the alligator here, and you attach the alligator to the back of your wire, and that's how you pace it. And you basically can do this. So this is enough for structural. Dr. Villablanca is one of the best structural doctors in the world, and he helped us with this case here, and it was an excellent result. The patient hemodynamically stable, no AI, no widening. So now back to the coronary artery disease. We are trying to kind of get through the iliac, so we have to dilate this left iliac, and we finally put a 45 centimeter sheath. And this is our setup pictures here. We have an 8 French guide from the right groin via 45 centimeter 8 French sheath, and you can see the calcification. 8 French guide will dampen every time we engage the left main, but so we kind of made it a little bit subselective. This is the caudal, audio-caudal view.
Nothing? No audio?
And basically we cross with the wire. Hussam, do you want me to stop here, or?
Yeah, I'd like you,
okay,
if you just, great start actually, and we've seen all the aortic valvuloplasty prior to going because of the severe AS. I'm going to ask my colleagues in here. You've seen the angiogram, 82-year-old, significant peripheral vascular disease, 8 French system, calcified left main. Hani, what would you do different? Would you do the same, or you have a different strategy? What they've started really quick, because for the sake of time, please.
Yeah, I think it's a very reasonable strategy. You have to just take away the hemodynamic significance of the severe aortic stenosis before you do this complex PCI.
Okay, Giuseppe from Italy.
What we do is to treat for first the reason of why the patient has been admitted. If the patient has been admitted because of the ACS, we don't do balloon valvuloplasty before, just we fix the lesion, the coronary, and then we move. Because when you go for valvuloplasty, actually, if you have an regurgitation, things like that is not probably the way to go. But in this case, you have to go without ablation, probably this facility is culture to do this complex PCI.
while Khaldoon and his team are working, we're going to keep on discussing this.
174,
Khaldoon, you keep on working. We'll do some discussion in here. Hadi, would you do 8 French system right heart cath and debulk it with a rotational atherectomy or something else?
I don't remember the last time I had an 80 French type of access, really. I won't. However, I think monitoring the right-sided pressures is essential in those cases. I noticed that the first question which they put up, Khaldoon and his colleagues, that there was an under-expanded coronary stent in the proximal LAD, right? That's what they said. It was done in an outside institution. And I think that's an important item to discuss in how to overcome an under-expanded stent, which was already deployed outside. I think, the first, I didn't see any imaging. You have to have imaging to understand what happened. Was the stent 1-to-1 size correctly? Was it really ballooned correctly or not? Is there a circumferential calcium, etc.? Then you will decide on the strategy afterwards.
How was the ejection fraction?
Hadi, that's a very good question, but they were not able to deliver anything. The balloon did not expand. But what you're talking about, how
Carl,
to
I
deal
think
with
we can't hear you because I think your microphone is under your mask or something. We can't hear you well. We hear the other ones.
Okay.
Yeah.
Can you hear me now? Can you hear me now?
So the question is
Okay, good.
When was the stent implanted in the LAD? If there was any stent.
You guys misunderstood. This is a balloon, and they could not expand.
Okay,
it
there
with
was
the balloon. So
no stent.
fortunately, they
It's
did
a
not
de
put a stent.
novo. Yeah,
There
failed
was
to
no
dilate.
stent. Yeah.
Dr. Wright?
Yeah, but
Any comments?
yesterday, the day before yesterday, we did actually under-expand the stent, and to Hadi's point, it took 10 minutes and 39 seconds of active road ablation at 200,000 RPMs to be able to go through that under-expand stent. So the dealing with under-expanded stent is very, very important parcel to this, but fortunately, we don't have that here.
Perfect. So this is not there's no stent before, so it's a heavily calcified distal left main disease. And Khaldoon, what size burn are you using?
175.
171.8.
So,
or whatever.
Khaldoon, I don't know.
Hi, Raj.
Hey, good morning, first of all. Question, what was your, do you have a surgical backup? Did this patient is a prohibitive risk for surgery, or did he seen by a surgeon before?
165.19.
Yes, he was turned down by surgery, and he's basically been worked up for TAVR, and we started with the coronary artery disease. The problem, the complicating issues, is the type 1 pancreatic cancer, and we talked with the oncologist, and the oncologist told us they have a curative surgery for him and chemotherapy. So they want us actually to treat the coronary artery disease and the valve as soon as possible, so we can get him in 3 months. We can get him for actually curative pancreatic cancer procedure. Go ahead.
Okay. So now you're rotablating.
So if you notice here,
175.
yeah, so we're rotablating the LAD. Our plan is to rotablate in the LAD, then rotablate in the circ, and finish with LAD circ left main bifurcation disease. So I just
168.17.
so our plan is to finish as I said the LAD circ, and then we'll go from there. Hadi, very nice hearing from you. Okay, so we advanced because we have a distal lesion in the LAD, and we basically gonna ablate it, and after that, what we're gonna IVUS. We're gonna do everything IVUS guided in this procedure. After we do the road ablation, we're gonna IVUS the LAD and the left main, and then switch and do the road ablation in the circ.
Beautiful.
You can do that. The one through probably will go. All right, you're gonna take the road out.
Yeah. So did you? Okay. We normally do really very good polishing runs. So to prevent, to kind of ablate the calcium, watch the guy. The guy is digging deep.
So, Khaldoon, what's your rotor speed?
So in this patient, we platform at 180,000 RPM. I changed my practice after the Diros study. I start going higher speed, and honestly, it's a counterintuitive. Like you have more platelet damage and heat generation. However, I've noticed anecdotally in my own practice less no reflow phenomenon after we do this. And this is a very good example about a case like unfortunately at Henry Ford, as Hussam Noor probably remember, we treat the most complex disease. Our case mix is literally unheard of in any other institution. Like everybody gets type A and B lesions, and we don't see that here.
That's right.
Fortunately, that actually gives us a lot of practice and training. So we do huge amount of numbers of CTOs, we do a huge amount of numbers of road ablation, CSIs, bifurcation. We've done 600 unprotected left main in 5 years.
You have one, you can walk it to yours.
So, and this is not by choice because most of our patients come, our surgeons are great, but literally those patients are so prohibitive risk. Ryan is one of the best robotic lima doctors in America. He's sitting right among you guys. We send him a lot of those robotic limas, but still some of those patients, like even Ryan, cannot help them.
Run through and front.
No doubt.
Agree.
So we've done rotational atherectomy at 180,000 speed, left main LAD, and I think now they're exchanging the wire to put in the circ and do the same thing, left main into the circ. 1.75 burr.
Exactly. We're gonna IVUS the LAD first.
Okay.
And if you notice, guys, we're not using a lot of contrast. The reason is the patient creatinine was 1.5 yesterday. We gave him a fluid overnight. His creatinine this morning 0.82, but still we don't want to challenge his kidney. And this is a trapper here.
And how is your right heart
And so-
hemodynamics as we speak, Khaldoon?
Traffic going in.
So the right heart hemodynamics, we did a baseline. His PA pressure was 60, and his wedge was about 30.
Okay.
Okay, ready?
So Dr.
So
Rad,
he's-
in your
he's-
rotablation,
but his cardiac output,
what
cardiac
speed
index
do you
was-
use usually? Would you use 180, you use
And
150?
rotablation?
I
180.
I mean, I leave it for him. I don't choose it.
Pardon me?
I leave it for him.
No, in your practice, have you
right.
increased the speed of rotational atherectomy?
Ryan is one of our surgeons.
I'm the surgeon.
He's
there.
one of our surgeons.
That's a conflict of
Surgeons
interest.
do it in a different way.
How about you, Hadi?
They just
You know,
just remove
you
the
don't. We
calcium.
don't
The
start with
surgeons, they don't
180. We
endosectomy.
start lower, but you know, you can go to 180 according to whatever you're facing during.
So Hussam, do you do a lot of right heart caths in complex PCI in your practice?
Yes.
Can we see the
Recently, as recently I'm saying about the past 2-3 years, I've been more liberal doing right heart cath in complex cases like that. Because if you noticed, the team at Henry Ford, they went, somebody said 8 French. So they knew from the previous failure. So they already know the anatomy. So they went the whole big guns to start with, and they are ready for it. So that's one advantage, of course, and they are a very experienced team as well. So if I get a case like this, I'll be ready with everything ready to do the best possible outcome.
What does the right heart cath add to you?
It would tell me about the hemodynamics. So I mean, as Hadi just said, wow, wedge pressure is up, right? So I'll be very, very careful if I give too much volume, if I need to give diuresis, or if I need to unload the ventricle. He already did valvuloplasty, and I know they're very big in MCS at Henry Ford. And this is why he did angioplasty of both iliacs, so that if he needs to do, if a patient crashes, he needs to put an Impala there while finishing the case. I'm sure Khaldoon and his team would have very low threshold doing that immediately.
I think it would be nice
Well
to have
said.
the IVUS plus the angio to understand exactly
Okay,
what
let's-
we're
let's-
looking at by IVUS. Otherwise, we don't know. Where
Okay,
there
let's
are
look at the
fractures.
IVUS. Scott, can you show the audience the IVUS?
Yeah, let's look at the IVUS now, guys.
I don't know if you
Okay,
have
let
the
him play, Aswad.
facility to do
So
a
this is
CT
the IVUS
vision.
after we did the,
Yeah, we see the IVUS.
yeah. We do, but we don't use it. You guys see the IVUS?
Yep. Tell us.
This is from a distal LAD to a proximal LAD. If you notice, we have a lot of calcium, but fortunately we did not see, this is post-road ablation, so if you see the reverberation, but I think this is an area still, there is a calcium fracture, you can tell, here, let me just stop it and go back to it here. So I'm gonna come back here.
Can
So
you
do you
spot
see
the
this
left main,
calcium
please?
disrupted?
Can you spot the left main LAD by IVUS just to tell us exactly what is that allow us to understand what is the IVUS at the level of the bifurcation? Because actually we're seeing the run
So
of the
this is-
IVUS,
this
but we
is-
don't know exactly where you are.
It's the ostium.
So this is the ostium, this is the left main here.
Okay.
You can
So
see
it seems that there are a lot
guide
of
little bit
fractures
because
So I think
Yeah,
you can go with
and
the
this-
balloon there and
and
the
this
stent
is-
will
and
be
this is-
expanded.
and this is the ostium of the LED. Do you guys see this?
At
See the
5
the
o'clock,
calcium
5
disrupted
o'clock, 9 o'clock, at 12 o'clock you have fractures. So that means
Exactly.
you can go ahead.
Exactly.
Superb.
Or should we balloon this?
So what
I
is your
should
next
think we should
strategy
balloon it
now
and stent it.
for all of you is to go for,
So-
I would go in this case for IVUS, LAD and CIRC. Before going with a rotablation to the CIRC, I would like to study by IVUS the two things, because probably I'm not
Giuseppe-
sure that we need in all cases to do that. For the CIRC,
Yeah,
what is
Giuseppe, the-
important for
the-
sure
the
is to
CIRC is
see
very-
by IVUS the two vessels.
Balloon, 30 by 40 balloon. So what we're
3 by
gonna,
40.
so what we're gonna do, Giuseppe, we're gonna at least work on the LED now before we go on the CIRC. And you're right, we can actually start by IVUSing the CIRC.
Yeah.
I have very little hope that we can deliver
will go
the,
through.
the IVUS to the CIRC. Yeah, I have very little hope that the IVUS is gonna deliver. But what we're gonna do, we're gonna secure the LED 30 by 40 balloon.
Anyway,
so we're gonna
this is
use
a
30
nice-
by 40 balloon.
This is a nice example to demonstrate that this lesion need to be used a calcium modifier, in this case the rotablation, because the thickness of this calcium is more than 0.5 and the distribution is more than 270. So in this case you cannot go just with a balloon, because it's not the case to go with the other option. It's an uncrossable lesion, so you cannot go with a lithotripsy. The other alternative is the laser, is the only one, other
Yeah.
device that you can use in this case. It's a very nice demonstration
Giuseppe,
of
they
the
failed.
importance of rotablation in this case.
Frankly, I think
Absolutely,
you
because-
wouldn't have
because-
happened without the rotablation. They already failed even crossing a balloon earlier, so. But-
In the meanwhile, you're working. Actually, this is a very important case. I would like to recall to the audience that there is just one randomized trial that compares SAVR against SAVR plus cabbage versus TAVR and PCI that has been published in Lancet. I was the one that wrote the editorial, so I have a conflict of interest in this regard. And actually, the result is in favor of what he's doing now him, because actually the result in terms of mortality favor this type of treatment,
16.
surgery in all patients.
At 16 atmospheres.
What do you think of the balloon expansion?
I need to improve my
So the
vision.
balloon expansion, I'm not happy with it enough, but
But it did
I'm
look
not happy enough
expanding.
with the balloon expansion. So it look expanded, but I'm not happy enough with it. So I'm gonna probably go IVUS again and see what we're dealing with, and the distal balloon expanded really good. So now after IVUSing, as you guys know, the shortcut study, randomized patient after road ablation to shockwave versus cutting balloon. And if you use road ablation, there was no difference between the two modalities in cutting balloon at a high inflation pressure. So this IVUS here, what we're gonna do, we're gonna decide with the reference vessel size So we can pick a shockwave balloon or a cutting balloon, and we can just kind of make sure that we have good expansion. We don't want to put an undersized stent in the proximal LID.
So may I say something? You know,
Okay.
it's important to do the IVUS in the two vessels. This is for the audience to be very informal in this discussion. We go with the IVUS and the circ before going with the rotation. Because actually you can go with a provisional stent. It's not needed to go with the two stents. But if you go with rotablation, pre-dilatation of the circ, if you have the section, you cannot risk to go for a T stent or other things.
I think that, I mean, I agree with you, but would you do that now before you fix the LAD, and whether we'll need to fix the LAD with the left main here or not?
But I would say yes, because the patient is very stable. The blood pressure is 140.
So you will go to the circ now and
Yeah, I would go
visualize it?
for IVUS in the two vessels, and then I would decide the strategy. Because
can
if
just
I
stent
go
it.
with the left main, I need to go for rotation and a mini crash, actually.
Okay. Stop.
Yes, I would actually just do what
Give
they're
us a
doing, just fix
3-0.
the mid-LAD to proximal LAD. Not go back to left main, but you can just
Yeah.
stabilize the area, forget about it, and then go to the circumflex before. Because it doesn't affect what you do, and your wire's there, and you don't want to take it out and put another wire in the circ when you're rotablating.
Why you have to take it out another
Well,
way?
we're
3.5
debating,
NC balloon, guys. 3.5 by 20 NC balloon.
but there's no right or wrong answer,
So-
actually.
so-
We can do both, yeah?
No, yeah. Ziad Ali was talking a lot about where the wire is when you're using the NC balloon, if the wire is in the middle of the balloon or if it's a bit eccentric, as a marker of lesion
Yes.
preparation.
That's right.
And there with the balloon, you saw it sort of towards the outside of the vessel, giving you a hint that maybe you need a bit more prep proximally.
Okay, we need a 3.0 by 48 synergy stents.
So, what's your plan right now, Khaldoon? We lost
Say
you
that
for
again.
10
I'm
seconds.
going now with a, I'm going with a 3.5 by 20 NC balloon for the proximal LID. And we're gonna go there, and after that we're gonna stent the proximal LID all the way to the proximal LID, and then we're gonna go after the circ, and we'll finish the left main after we decide if the circ is well expanded or not. Okay, good. Not too much.
There is a question from one of my panelists, says we need an angiogram, and I think what they're trying to do is to minimize contrast because they had already enough information by the IVUS, and because of the creatinine is elevated, they don't want to do the unless you have any other reason why not to do an angiogram here. Khaldoon.
So, absolutely. The creatinine is 1.57 yesterday. We hydrated the patient, and we don't want to challenge his kidney. We have enough information. Actually, the 3.5 balloon expanded really well. Come back to the left main. And so that's why we don't do angiograms until the final. We literally can done these cases with 10 cc of contrast. So the IVUS, can you guys show, Scott, play the last IVUS we've done. We're gonna play, show the IVUS, play it. Okay, good. So it looks here, we just push dilating and we're gonna stent. So this is the IVUS. We started distally too. Again, we are actually
Can we
good
see? Can we
with
see
the IVUS.
also? Can we see also the angio just to match the location of the
Stand.
IVUS with the? Yeah, please. It's important for the
Yes.
audience and
So
for us.
Show us the angio. Giuseppe, we have ST elevation now, so what we're gonna do, we're gonna stent, and we will take an
Yeah, this is the
angiogram
reason why
after we
I
place the
wouldn't
stent.
do anything more just to evaluate what we have to do, and that's.
Yeah.
Yeah,
Okay,
this
so,
is more. I wouldn't go to manipulate further the situation, but I would fix, the reason for ST elevation now, the hemodynamics.
I need a 3.5 by 48
You
synergy.
can breathe and
3.5 by
relax.
48. Open it.
Khaldoon, are you planning to wire the circ or no?
Yeah, we will wire the circuit after we deploy the stent. We finish the LED. We're not gonna jail the circuit. We're not gonna jail. Yeah. Good.
But you can see how easily they were able to deploy or
long
the stent after modifying the plaque with a rotational atherectomy and non-compliant balloon in a very heavily calcified
Is it
vessel.
38?
Yeah.
How long is it? 38?
It looks like
meter?
it.
This is 48, 48.
48,
3,
48.
3 by 48 synergy.
It's just to
Yeah.
reinforce the comments
Actually,
of the chairman.
you keep it.
How easy it was to get down with the 48.
Let's use how long.
I mean, Khaldoon, keep on working. We have some
Okay.
side discussions here. I mean,
We need the
when you do
24.
only
Give me
balloons and even
40 by 24.
Shock wave, and you would not have, because you basically shave the calcium versus cracking only the calcium. So this was a shave, and then you ballooned it. So that makes the deliverability kind of easier if it's only balloon inflation.
In this case, the calcium is mainly luminal, it's not adventitious. So the vessel is not too stiff. So actually, and not too much tortuous. But
Absolutely.
the point is absolutely well taken. When you make, it's not just a cracking.
And they're from Henry Ford. That's
You know, the other thing, he did the water ablation before the IBIS, actually. So in a way, we are lucky that the calcium was superficial. You know, the water ablation worked beautiful here because it's superficial, as you said. If it was deep-seated, it probably could not given him the same result.
But if it was very deep, they would have been able to balloon it earlier, so it just gives you
Megatron? Give me Megatron. Which one is this?
So at some point,
I need
we
a
would
40 by
like to
40.
see an angel.
By 24.
I know the
You-
coronavirus is a problem.
Yes.
But actually,
Khaldoon,
outside
the
it's
team here has a
important to
separation
understand.
anxiety of the contrast. Don't shoot any contrast till the end.
Yeah. I'm against zero contrast. I'm against zero contrast.
Separation
We are,
anxiety.
we are a pro 10cc contrast.
There you go.
We're gonna
How
have
is
to
the
see,
patient now? How is the patient now? The ECG and the hemodynamics.
Patient is good. The
better.
ST is actually getting better. Yeah, the ST is getting better, and the patient is doing better. We're gonna have to take a little bit of puff so we don't jail the circ when we deploy this proximal LAD stent. So we will take a puff. Good.
And you know why it's important to make an angio? Because by IBUS, we cannot understand exactly if you have the same number of vessels then the patient got in the lab. Because we don't know about the diagonal, the septal, what has happened with root ablation, post-dialysis. So one angio is important to
Good.
have.
There you go.
Forward.
It's just positioning.
Forward, yeah. We're just positioning. Okay, good. Okay, we're good. Okay. You got it.
I need help.
And also, you'll miss slow flow, you'll miss perfs, you'll miss a lot of things as well.
Lot of things.
Yeah.
That's true. That's why we're gonna take a picture now because I'm not sure if the ST is no reflow or slow flow. We have no idea.
Do you have any ECG
Okay.
changes as well, Khaldoon?
It's coming down.
It's coming.
ECG are getting better.
Khaldoon, if you are going to stent proximal LAD to the left main, isn't it the time to have a wire in the circ? Just, you know, that will make me feel better at least
No,
when I work on it.
Yeah, we're not gonna stent the circ before we wait, good. We're gonna wire the diagonal. If you guys notice, the diagonal has a clot hanging in it probably. What was the last ACT, Chantal?
338.
Can you give us some anomal?
When was that?
Can we see the
Okay.
hemodynamics? Can we see the hemodynamics and the
Yes.
ECG? Can we
Okay.
see the ECG on the patient?
Yeah, Scott.
It's a little bit
Can you put that
it's the elevation,
hemodynamics
but probably
picture?
it's related to the branches. It's not the LAD, I think.
Yes. So, yeah, the LED has an excellent flow. I'm going to show you this here again. So the diagonal is a large diagonal. I'm going to balloon this diagonal only. I'm not going to actually stent it.
You don't have a normal.
Anyway, I don't know what you do in this case, but in my institution, what I used to do when you have
What was the
time,
ACT?
when you fix all the situation, is to go with a bolus of adenosine, and many times you sorted out, you know, the situation.
Chantal.
A very high bolus, that means
Yeah.
5 times higher, and this adjusts for a minimum normal flow that you have in this case.
Oh, it's 300?
No.
So we don't have any short.
Give me
short
another
or
run
normal?
through, Chantal. Okay. So what we're gonna do, the bolus, we don't have really nori flow, Giuseppe.
You will see
all
that
what we have,
it
we
will
have
be
a-
better. It will be better. So the last point is,
Yeah.
I don't know what the panelists think about that, is to make, I know that you're against the angio, and most of the panelists are against the angio, but to understand if it is a true Medina
get some
is
Manalo
important,
and Josh
because if you
Yambro?
This
don't
is
want to
also
go for
300.
the IVUS, I think it's important to
Hey, guys.
understand the angle,
It's right
and
there.
if there is the ostium or the circuit,
What about
it
this
is highly involved in the lesion. But it's a second step.
So we're gonna dilate the diagonal, and we're gonna actually add another stent, probably, approximately, and then we're gonna go fix the LAD left main and get it taken care of. And we'll finish. I don't think I'm gonna finish with the DK crush. The reason is we have a short left main. If you do DK crush, I'm not sure it's gonna be really that beneficial. I just wanted to see the hemodynamics, and the ST is going down significantly. We're gonna dilate the diagonal, and I need a 3.0 by 20 balloon for the diagonal, please. Open it.
Did you do the adenosine?
No, we have not.
Okay.
It's not nori flow, Giuseppe. We don't have nori flow. Okay. We have a 3.0 balloon. Open it. Yeah.
20.
Yeah.
Oh, 15.
15 is fine. Doesn't matter. All right, and now we are done with the LED. We're gonna go actually wire the circ and we're gonna listen to Giuseppe. We're gonna wire the circ, and we're gonna try to IVUS it first. And if the IVUS goes, I think everything will go. If the IVUS doesn't go, we're definitely gonna probably rotablade it.
I think we'll go.
How is the activated clotting time that you have during this complex procedure?
338.
How is what?
The ACT.
Yeah.
Activated clotting time.
The ACT 300
300.
activated. Yeah, it's at 300 and above. Back.
Yeah.
Back a little bit more. Good. No, too much. Good. Yeah, we normally 300 and above. If you go in retrograde in cases of CTO cases at 350.
The osteal LAD
Perfect.
and the osteal LAD here looks.
Okay.
What
Okay.
you doing now?
This give me a Manamo. We're gonna wire the circ, and we're gonna try the IVUS, and if not, we will roda. We're gonna have to remove the LED wires. And do you want to put a stent in the LED? Do you want to put like 16?
No, so you saw how that knuckle went? I think it'll be fine. The knuckle was easy to dive.
In the meanwhile, you look by IVUS. Just probably you have seen, but we have not seen. What is the angle between the LED and the circ? Is more than 60 degree? Is a sharp angle? Is 30 degrees? I think it's
a
important
90
to know
degree-
also
it's
this
a 90
because by
degree.
IVUS we cannot understand that.
You said 90 now.
90.
It is 90 degree, literally.
90 degree.
Like we can show you the. Yeah,
No,
we
but
can show
thank
you.
you,
The,
we
we can show
trust.
you the column. Do you see guys?
That's right there.
Do you see it?
Yeah.
Now we see it now.
Yeah. So
Yeah, it's
it's a
90.
very sharp, very
So
sharp.
if by IVUS the minimum luminary is okay, I wouldn't do anything. I would go with a direct provisional stent. And that's it. Just to keep the things as
Yeah,
simple
so-
as possible.
So I prefer single stent strategy up even now. Okay, if I can get away, especially now America. Finally, we have drug-coated balloons, guys, in America. So can you push the screen down? Okay, you are outside.
The other thing,
So
the circ system is a small system actually. It's not a large circumflex. And there is a totally occluded OM, which
Absolutely.
seems to be sizable after all.
Absolutely.
So I agree with you. I mean, I would go with the provisional type of approach here.
Thank you.
After,
No, thank you. This make my day. Thank you. Thank you, my friend.
I don't know, let me find a way to disagree with Giuseppe then.
Yeah.
Just, I can just,
No, you have to disagree.
Okay, yeah.
Khaldoon, which wire are you using here?
We're using a Manama wire. We have a run through in one vessel. We have Xi'an blue in another, and now we're using the Manamo in the circ.
Thank you.
Okay. So
While the
I like multiple wire.
Nice.
Okay, good. All right, let's go with the IVIS. If the IVIS goes in the circ.
I think the answer is the IVUS now because I'm pretty much sure if you put there physiology is negative in the circ because it's a really small vessel, it's not dominant, left circulation. So for me, the only way is to keep it open. That's it.
I think the OM is above it. It's above it.
Track it and keep it.
And he's going to have, he's 82, he has severe aortic
82,
stenosis.
severe aortic
He's
stenosis.
going to have the TAVR done subsequently. One of the challenges is if the left main, when you have very short left mains, are always very challenging. I found when in my practice, and I get very short left main, I try to do provision as much as possible because of the things that the team and the panelists and everybody discuss. So we gotta be careful with the short left mains. It's not that short.
Good.
Here's another angio.
We took a picture for you, Giuseppe.
I see.
Okay,
but,
good. Because we had.
but this is my feeling actually. You stay there, you're the master. But the point is, if for me, the circumflex, if the osteum is not 95%, I would leave it.
Yeah, it's, honestly, I practice a lot of tap.
But
too.
it's up to
Depends
you.
on the
It's
patient.
up to you. It's up to you.
Yeah.
You're
Yeah.
the man now.
So we will see the circ. I believe in complete revascularization, and we're gonna okay. So the IVIS is not going, Giuseppe.
Yeah, the IVIS doesn't want to go.
No, it's not gonna go, especially the bend. Okay, don't bend the wire.
Can we see
Okay,
the
give me the
picture there?
microcatheter.
Can we see the picture of the confluence there with the IVUS?
The one you just did, yeah?
Yeah, push it just to
For
see
the
where we
confluence,
are.
we can go. Yeah. Can you do Livus?
Up with the IVIS.
This is,
Let's see
Okay,
the
so this is the
confluence
left
there.
main.
it's he can't cross.
Anyway, I would go for keep it open. That means one stent in left main LAD. That means that if you don't touch the circ, you won't have any dissection. With 90 degree, you will cross again with the wire.
So that's Giuseppe. How about you, honey?
100%. Same thing. Just keep the Timmy 3 flow in the circ. That's all you need. He's 82. He's not running marathons. He's got severe aortic stenosis.
Yeah,
Timmy 3 flows enough.
I totally agree with my colleagues. I think I'll finish the LAD, the left main, have the circ protected by the wire. And the last angio, when the PA coded, the circ distally is diffusely diseased, long segment, small vessel, and the first OM is almost totally occluded. So I'm not quite sure I would touch it now unless it's needed badly.
Anybody from the audience have any?
Khaldoon, can I ask you? I know we believe in complete revascularization in Ford, but if you're gonna stent that prox circ, are you gonna even go down with the OM, or you just gonna do the proximal circ and that's it?
No, we're gonna rotoblade it all the way down. You can't even advance the microcatheter, so yeah, we're gonna rotoblade it all the way down. And give me the roto wire, please. So we can't because this circ, although it looks diffusely diseased, it's not really small that much.
Is your plan to rotoblade and use a DCV or to stent?
If I rotoblade, I'm gonna stent.
Khaldoon,
The free
Khaldoon,
cage study showed that stenting is still better.
I think we'll let Khaldoon and his team to carry on,
Yeah.
and we can discuss here. So I think when you see microcatheter going down there, he's going to change the rotor wire and he's going to rotate left main to the circ. And then the options would be either basically balloon it, only a stent across, or DCB, or actually ended up with maybe a tap procedure, a two-stent strategy technique. I mean, you guys keep carrying on. I think the issue of the complete revascularization, and I need to say that to everyone, it's one size doesn't fit all. yes, we believe about
Yes.
complete revascularization, but a gentleman with 82 years old, severe aortic stenosis, peripheral vascular disease, I will do the one which I can purchase the best, which is left main LAD, do the TAVI, and if he is symptomatic from the circ later on, I can always get back and do some more work. But of course, I mean, and again, it also depending from an operator to an operator, an institution to an institution, experience to an experience. So all these things have to factor in before you make the final decision. So we have to respect all of these together for the best for the patient.
Hussam, do you mind if we
Absolutely.
vote in the room, provisional versus two stents?
Why not?
Like, can we vote?
Okay, this is behind the scene. Who wants,
Yeah, behind the scene.
from the team here, who wants to do provisional stenting? Raise your arm or hand.
Oh, wow. That with the panel.
Standing ovation. What
So-
about the two stents? Two stents.
Two-stent strategy. Okay, so we have a handful.
Only the brave. Only the brave.
Handful here who is thinking about two-stent strategy, and the majority of our colleagues in Dubai on Thanksgiving Day wants to do single-stent strategy, provisional.
And the other thing,
So I agree with the single stent strategy, provisional, if you don't have a disease, right? So if you have a good vessel, but this vessel has two major branches. The first OM is actually the smallest, and we are in the biggest second, the second OM. And what we're gonna do, we just gonna treat the proximal part of the circ. Actually, we're going to treat the middle of the OM. So the provisional stenting, if you don't have a diffuse disease and if you don't have the disease target to treat, I normally agree with you. 82 years old. If you can do it safely and fast, I think you should do it. If you have a problem, can you go straight? Open the brake, please.
Absolutely. And what size burr are you using for the circ?
Same burr.
Pardon me? Same burr.
1.7.
Same burr. 1.75.
1.75.
Okay. Okay.
The big burr.
No dyno.
No Diana. No Diana.
The brake? The brake?
Open the brake. Yeah.
I got it.
So the,
Go.
I think everybody knows about the burr sizing, but I mean, the panelists think that the burr size is too large for the vessel that we see angiographically from 4,000 miles away.
I think so.
Hey, okay, good. Stop. So, we're gonna take the LED wire. So listen, guys. I agree with you. I think in North America we have big vessels. Okay, good. I got it. Okay, stop. Let me do this. Okay. So basically what I do in the circ, because there is what I'm gonna do, I'm gonna pull the guide and make it kind of go more toward the circ, so I can remove the angulation, if you notice, because if I put the guide toward the left main, now the guide looking toward the circ, so, and we're gonna pull it back here and make sure everything is okay, and then
So that's a brilliant trick. He made the guide and the burr coaxial so that he will be able to cross that.
One thing that sometimes when you do the rot on the circ is the conduction disturbances that you might have, during the case.
we give aminophylline.
They give routinely aminophylline
Okay.
before that, so that it would mitigate the risk of bradycardia. Let Khaldoon
Yeah, the
concentrate.
aminophylline actually stops.
So one thing that's also, while they're working, is if you use the rotational attraction a lot in another vessel, the diamonds could be removed from it. So if the burr doesn't pass, you change to a new burr, because you denude the surface of the burr if you do a lot of rotablation. So if this is non-crossable, you may take another newer one with a higher speed as well. Yeah.
So we only use the perb for 2 minutes so far. So normally 5 minutes, you're right. And actually for the audience, the wire fatigued in 5 minutes. So you have to be careful about that.
And notice that he's not doing the picking movement. He's just pushing and pulling back. And I think this is really, really good. Very nice demonstration of utilization of rotational atherectomy.
It's also very nice mechanics, Hussam. They've moved the guy to take away the wire bias just to help them, angulate it better, right?
That's okay. Okay, so the wire, what is that beeping?
That's the sensor. 173.10.
There you go.
157.15. 174.19.
Okay, so this is what I hate about the wires. The wire keep kicking back. I normally use a supportive wire in those situations. So basically to give me better guide support. Here we're using a floppy wire, but things are all still good.
Yeah, it's going well. It's just a matter of time and patience. The key point is not to rush. Did you increase the speed?
169.5. 173.10.
I just think it's too big.
173.14.
I think the bird's too big for that vessel. Too big, yeah? Too big.
1.7.
Because the proximal circ, do you think it's less than 4.0? I never seen a proximal circ less than 4.0. What is that, Beacon?
May I have a question, please?
It's
reading the heart rate.
Naya, can you change the
I
parameters,
think
please?
going with the 175 with this angulation and it's a very big bear to go with angulation as steep as the LCX. So it would be, in my opinion, to
What's wrong with the
upgrade
patient?
the bear size with at least one, if not two, and then take the bigger
Urinal.
one.
Yeah.
If it didn't work with the extension, but I think with a smaller bear, just downgrading it would do the job, and then we can take the bigger bear.
I think let us just watch here. Let him concentrate on the case right now. We'll just keep an eye on what's going on. We'll keep the comments after we cross it, sir. I want them to concentrate on the case right now.
We can actually downsize to be able to easier to cross, because our target here not to basically ablate the plaque. Our target is just to break the calcium.
I would stabilize
you
the
assess?
hemodynamics now of the patient.
Just coming up, the blood pressure.
Yeah, so hemodynamics has, because we give nitroglycerin and nitardipine in the flow, we don't give verapamil. So that's what causing the blood pressure to go a little bit down. Patient wants to pee, which is good.
What's
you're
your,
right,
what,
Giuseppe,
what's your
we're gonna
wedge
just
pressure,
stop.
Khaldoon?
The wedge pressure was 30 at the beginning.
Still?
But I haven't measured it again.
169.5. 170.10. 170.15. 172.17.
This is my not go, you're right, guys. See what the patient has.
Are you okay? Okay.
Oh, okay, so he needs a urinal. Okay, let's give him a urinal. We're gonna give him a break. The patient wants to pee, so we're gonna put a urinal while we're waiting. So if you guys notice, we don't wear
We're gonna
leads
put urinal.
because this is the round part. We're using the round part here.
Okay.
And both Aswad and I don't use not wearing lead. And actually our live monitor there to see our radiation, gives us instantaneous feedback if we are getting radiated. So we adjust the machine, we adjust the setting.
Sorry.
So that's amazing. I mean, the rampart or the radiation shield, and I
You
think
can go now.
radiation
You have the urinal.
safety is very, very important.
Okay, keep your hands down though.
Absolutely.
And back safety.
And back safety, because the orthopedic injury from the lead is really substantial for the interventional cardiologist. Most interventional cardiologists have back pain. A lot of interventional cardiologists have cataract.
While you're waiting for the urinal, do you think you're going to stay with the same burr, number one, or should you decrease the size to 1.5, or the same burr with maybe 210 or 220 RPM speed?
No, I'm not going to go higher speed, Hassam, but what we might actually decrease. The problem when you disengage the guy, when you get the burr in, you lose all pressure. Like you lose support.
Do you think?
That's one of the.
Just one comment just to discuss also.
Your hands are tied
this
up, yeah.
point. Considering the hemodynamic that is not perfect, would you go with an angio after this rod ablation? Just to understand if the left main is suboccluded now. To see why we have this low.
So his EKG is actually not getting worse. So what I'm going to consider, one more run, and then I'm going to actually change strategy to different. Now I can deliver balloons, and I'll see if the balloon deliver, and I don't have to burr anymore.
So yeah,
That's
Khaldoon, that was
my consideration.
Khaldoon, that was going to be my question. I know you do a lot of these, but what will be your threshold to when you have hemodynamic instability to try to do a look at angiograms, particularly with this acute angle of the chest?
Yeah, I will do it right now.
Can we see live angio, please?
Hemodynamically good.
Can we see the angiogram?
Let's take it out. Okay, we're taking the burr out, and we're going to take a puff.
Okay, so this burr didn't cross as well. So you're going to exchange it.
Okay. So we're going to exchange it. Don't lose the wire. I need the microcatheter.
It's right there.
So you're going to exchange it to the same size or a smaller size? Or are you going to do
No.
balloon?
I'm actually going to, I'm going to just do balloon. Because I want to see if I can balloon it and I expand it, then I'm going to use a different ablation strategies. Like I'm going to probably use shockwave if I can deliver it, or cutting balloons. But
I think you can take
but
time.
now-
I think you can take your time. For the moment,
Would you like
I need 2.5 by 40
humbly, I
balloons.
believe that we need an angio now.
I took a puff, Giuseppe. The LAD looks fine, the left main looks
Okay,
fine.
please, when you
The
take it out-
circuit itself has a slow flow.
2.5 something.
Hemodynamics is getting better.
2540.
2530 is
Yeah,
okay.
hemodynamically is getting better. So you guys have to understand, we've given a lot of vasodilators in Rhoda flow, the Rhoda glide. So these vasodilators what cause the low blood pressure. A lot of times I give those patients levo drip to keep it. So these hemodynamic, it did not look like, I got it right. It didn't look like we have ventricular collapse. It just vasodilation because of a lot of vasoactive drugs we gave in here.
The other thing about the circ, when you put a lot of rotational atherectomy and you do prolonged one, you get ischemia, get ischemic MR, in which you drop your blood pressure as well. So, but they're very, very, very fast in recognizing all of these things, yeah? Because you see the hemodynamics immediately improved. I don't think the circ is occluded.
No, the hemodynamic improved immediately after we basically removed the Rhoda flow, the Rhoda flush, because that has a lot of. Okay, I need another wire to wire the LED.
That's right.
That's right.
So wire changed over microcatheter.
So we changed to workhorse wire now, and
And maybe Khaldoon, give us a 3 cc injection, please. I'm the middleman now.
Okay, let me just put the wire in the LED, because I don't inject now, because if I have a dissection, I don't want the dissection to propagate without a wire and the LED. Let me put
That's
the
very
wire in the
true.
LED and I will do it.
That's very true.
Okay.
Here.
Well,
Wait.
give me another wire.
It's ready there.
Don't come.
12, 14,
16.
16. Okay. Down with the. Okay, good. So I'm gonna let me put a wire in the LED. Okay, good. So if you notice, we trapped. We always after we trap, I bleed the guide, because a lot of times you trap air. So my trapper trapped my wire. So now the wire is not functioning well for me. I'm gonna get the wire outside so I can unfold it. And now I'm gonna get the guy back in and see if we can wire the LED. We went into the diagonal.
Wanna
That's
keep
okay.
it?
Khaldoon, no pressure. Keep working. I think I was told we have 5 more minutes of lifetime.
Going in.
But you guys doing really
Okay,
an
I'm gonna
amazing,
take you-
amazing
give me
work.
5 by 40 balloon.
There it is.
Yeah. Okay, so we're gonna
Circ, right?
Circ, yeah. Phenomenal.
But the strategy is very clear. I mean, the strategy is that, take all the guns that you need to take, try to modify the plaque and calcium modification as much as you can. Do whatever it needs to be done, not too complicated, and to get the case done. And take all the precautions that needed to be ready if something goes wrong. And that's been very much clearly identified from the beginning of the case. So that's really cool.
Yeah, so basically, if you notice here, this is the circ. The balloon is actually expanding,
Nice.
except one spot. What are you?
14.
Oh, 16.
Flying balloon.
16.
Yeah, we saw the balloon it actually flew in.
Good.
And I think that is partly related to the 1.75 burr that you were trying to cross earlier. That probably facilitated the passage of this balloon at the inflow.
Yeah. So we have distal lesions up. So we're gonna dilate them. So the balloon went, and now we're gonna take a picture down. So this area expanded. We only have one spot identified now. I can actually literally use a shockwave in that spot, because now the 2.5 balloon took it. Here we go.
Yeah, you did. Here's your angiogram.
Are you guys happy?
Everybody's happy.
Good. All right. Let's go with the IVUS and the circ, and we'll see if the circ, if we can get an proximal circ.
Ostium.
Ostium, yeah.
Guys coming out.
So the ostium, we dilated it, but we're gonna, we rotated it. Okay, go up. 16. So this is just we dilating the ostial circ down. We're gonna go rota.
IVUS.
We're gonna go IVUS, sorry, not rota.
It's going to IVUS the circ
Okay.
system.
Circ. Yep. Okay. Go IVUS. All right. So we basically are able to do all this work in a record time. We've not really stressed out, despite the patient not being on hemodynamic support. I got to tell you one good thing about hemodynamic support. It gives you a little bit of kind of relaxed. You don't see these hypotension episodes that much. And this actually was born in the BETAS trial in the UK, that long old trial. Okay, so now we are in the proximal circ. I want you to see 1, 2, 3, 4 millimeter vessel, guys. This is the circ. So as I said,
We don't see
see the
the-
IVUS.
no
Khaldoon.
proximal circ.
We don't see the IVUS. Can we see the
Can you
IVUS?
guys put the IVUS on?
Tariq, you have a comment Tariq Helmi.
But this is the confluence.
I'll wait.
This is not the host. It is just the origin of the
No,
circ.
look
But
at the
actually,
iris.
the vessel is very small.
See,
It's not four.
no, this is a 4 millimeter vessel, Giuseppe.
No,
This
for
one,
me, no.
2, 3, 4 millimeter
No, but
vessel.
this is the confluence. You're taking also the left main, I think.
No, look at the iris. I
I
showed
think
you the
so, but
picture
if
of the
you get
iris.
a
The
little bit
confluence has a
deeper-
wire in it.
If you go a little bit deeper, probably we see it better, but I can imagine it is different.
That's okay, Tariq. You have it.
So, Khaldoon, this is Tariq. How are you?
Hey, Tariq, how you doing?
I am well, thank you.
Okay, I can't get the iris more than that. Record.
So now that
Okay, we're gonna dilate it
you've
with the balloon
invested
again.
some time in the
301
circumflex,
C balloon.
are you going to do a do-stent strategy for the left main, distal left main?
Oh, it's, we have it.
Yes. Yes, we're gonna do a two-stent strategy, and it's gonna be DK Kulat.
Iris coming out, 3020 NCs going in.
What's the LED?
I could actually use a DCB, but like,
Khaldoon, I think you guys are doing an amazing job on a time of Thanksgiving, and we really want to thank you again. And I'd like to see the team because we're running out of time. But clearly, if I could summarize it, I know you guys are busy. You really, the team at Henry Ford showed us a very complex case from all discipline anatomy, from the inflow, the legs, from the heart valve, from the coronaries. And you have demonstrated exactly the steps that you've been taking. I think the safety was the first thing in which you are ready for anything if it goes back wrong. And then you've rotablated the LAD. We had some debate whether we should do professional or do two-stent strategy, but we always leave it to the operator on the stage to make that decision. I think from the team of Gulf Intervention Society, from Dubai, and everyone here, we really thank you very much and appreciate that, and happy Thanksgiving. Thank you so much, Henry Ford, Detroit. Thank you.
oh, thank you guys. Thank you. Thank you guys for the.